I didn't know, you're
And we feel like we're
Good afternoon, ladies and gentlemen. Welcome to our Opioid Advisory Committee meeting this afternoon. Thank you for being here. Looks like all of our folks are present except Dr. Frank and
Hannah Houston.
Hannah Houston. Do we have others absent?
We are missing Dr. Rivers Woodward and Dr. Paul Holden.
Okay, and Dr. Holden, I think, indicated he would not be able to be with us today. All right, I'll remind you to silence your mobile devices and take care of that for us, and then I'm going to recognize Brandy to do our invocation. Brandy? Invocation? That's
Gracious Heavenly Father, Lord, we just ask you to come here with us today, Lord. We ask that you would guide the ideas and the conversations that are considered here today, Lord. We ask that you would just lead us in the direction that you would have us to go, Lord. We want to take everything into consideration, Lord. We want to do what is right. We want to help the people in this community, Lord. We want this to be a thriving, healthy community, and we ask that you would just point us in that direction, Lord. We ask all these things in your mighty name, Lord. We thank you and we honor you in Jesus' name. Amen.
Amen. Thank you. We'll ask Mr. Carver to lead us in our pledge of allegiance. If you'll stand for the pledge, please.
Join me, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you very much. Ladies and gentlemen, you've had the agenda for just a little while. Any questions on the agenda? If not, I'll entertain a motion to approve the agenda.
I make a motion to approve the agenda.
Okay, thank you. Do I hear a second? Thank you very much. All in favor, signify by the uplifted hand. I believe that's all of us. Thank you very much. I don't think we had minutes presented from our last meeting, or I didn't see any minutes.
They were sent out as an attachment previously. Did you guys receive the agenda packet? I believe last month.
So it's been a while? Okay, I was looking for a
Yeah,
minute.
it's been a little while.
Okay, well, we'll approve the minutes. Do I hear a motion second? If you've had, did everybody besides me get a chance to, maybe I read them and it's been so long I didn't think about it. Everybody okay with approving the minutes? Do I hear a motion second? Have a motion second? All in favor, signify by the uplifted hand. I believe that is all of us. Thank you very much. Okay. All right, that brings us to presentations and update from our coordinator. We'll recognize Dr. Samuels for that update.
Did I turn it on? Okay. Yeah, we've talked a lot about the direction that we want to go in, but I wanted to spend a little bit of time talking about some of the things that we are currently doing and mention that we have some reporting due to the state. So we, after some time, we have received our naloxone vending machine, which will be our community health vending machine. And that was through a grant from Blue Cross Blue Shield, and that will be located at Catawba Valley Healthcare. So we have the machine, we have naloxone from partners and from the state to be able to stock it. And we're also looking at including some community health items as well, such as hygiene products, socks, toothbrushes, those types of things in there. So really excited about it. It's an opportunity for us to serve the community. We can even add in like school supplies before school starts, and we have the ability to be creative there. And we appreciate the partnership of Catawba Valley Healthcare as their the machine is at their site, and they're helping us maintain that and manage it. So happy to report that we have our first ever community health vending machine in Burke County. So we're expecting to go live with that in a couple weeks. The annual report for opioid settlement is due 90 days after the close of the fiscal year. So we're looking at having that done in September. So what we'll do is I'll build a report. There's a financial piece of it that our finance department will take care of, and then a programmatic impact report. So I'll go over that impact report with you guys at our September meeting, and then we'll get it finalized to submit to the state. And it'll talk about things that we have done, the impacts that we have made with money that's already been spent. So it only includes dollars that have been spent in the last fiscal year, which will be recovery court, mine and Brandy's salary, and a few other small things that we spent last year. So we'll go over all of that, and I'll present it to you in September. For recovery court, this is one of the strategies that we have currently funded. They have 15 active participants, 3 waiting, and they had 3 graduations this month and last. So they're reporting some good numbers from that program. For Peers Partnering for Excellence, this was also a previously funded strategy that remains ongoing. It's a group of peer support specialists that live and work in Burke County. And I think we've talked some about peer support specialist and what that certification is. And these are folks that live, work in the county, understand the resources, boots on the ground, and have a more comprehensive understanding of what is here and what the gaps are than most other people that work in the profession. So we're really fortunate to have that group that can also make recommendations for what gaps we need to fill. And so they've done a lot of good work over the last year as well with some awareness initiatives, and they are working on an event for National Overdose Awareness Day, which will be pretty neat Brandy's at the end of August? So we're looking at dedicating a tree, and that group is working to get donations and to set up the event so we can have a really nice memorial and observance of that day. And I think, Brandy, is there anything that you want to add to that for the peer PPE or recovery court?
I think that it's just important to note that one of the things with the PPE is that we recently joined into a community partnership with the Hope Center, which is the Burke County's Recovery Community Center, the RCC, and they have recently asked us to become the advisory board for the RCC. So we have taken that position. The Peers Partnering for Excellence has taken over as the advisory board for that. We hope to grow that into a much larger recovery community organization, which is a much larger organization, and see that grow in our community. That would enable us to provide many more peer support services throughout the community and not just be in one place. Also, I would like to see us do some little P and big P work, so policy change and programmatic change. We've already started discussing that. Jerry has joined our PPE group. Karen is a part of our PPE group. Katie's a part of our PPE group. We have a lot of folks who are joining that from the community. We have a lot of agencies who are interested in the work that we're doing at the PPE group. A lot of agencies are on board with us helping them create tools to better enable them to support the peer support specialists who are coming on board with their agencies. I think that's important. There's not a whole lot of post-certification support for peer support specialists, however, there should be. Also, we're looking into peer support supervision so that we can provide that type of support for our peer support specialists. But if we can start getting into some programmatic changes and policy changes, I think that that would be something that would really benefit our community, from the peer support specialists all the way up to community and systems level change. So that's something we're looking forward to doing. We want to be a professional association, and I think with a little more time, we can really make that happen.
Thank you. And that concludes my presentation for just what's going on now in the world of opioid work and the things that we're doing, so we can move on.
Thank you, Katie. This time, we'll open the floor for any informal public comments. Do we have anyone here this afternoon to make any public comments? All right, seeing here none, I'll close the public comment, and we'll move on then to item number 9, items for decision. Again, we'll recognize Katie to present suggested programs and strategies and RFP submissions. Katie.
Thank you. So we're going to talk about, I want to review with you our priorities and focus areas, because that's the lens through which we're going to be evaluating some of the strategies that we approve. And then we're going to go through the budget recommendations that were motioned to move forward from last month, the proposals submitted through the RFP process, and then get some directions and next steps from you all. So our purpose and values. And our focus areas are reduce onset of new use, evaluate pathways to recovery, and reduce fatalities. So those are the categories that we're looking at as high impact strategies, looking to fit our initiatives into these buckets so that we can make the most impact, and then also measure that impact. So a continuation from last month, we wanted to move forward with, staff move forward with building a recommendation for 3 strategies: PORT, post-overdose response team, community peer navigation, and naloxone distribution. So in the past month, we've been working with the different departments to build a budget around what this looks like, and also like what does the operation look like. We're looking at a 24/7 schedule for community paramedics and peer co-responders, joint field operations to respond to overdoses, connect individuals to services, and reduce repeat incidents.
Excuse me, Katie.
Yeah.
You guys sitting over here, I know I certainly couldn't see it. If you're interested, it's much bigger and better to see behind you. And you may already know that, but I just invite you to turn around if you'd like to see that better. So I'm sorry, Katie, go ahead.
So we're looking at an initial timeline of 1 year for funding, and then we have also set some metrics where if we're able to meet those key performance indicators, it will go into an automatic 2-year extension. And so the SMART goals, or the indicators that we're looking at, is engagement rate, a minimum of 60% engagement with the peer support services, a 15% reduction in repeat 911 calls for non-fatal overdoses, 10% increase in availability for high priority calls, at least 150 referrals to treatment, harm reduction, housing, or support services. And the PORT team will complete follow-up visits within 72 hours for at least 60% of non-fatal overdose cases. So these are the benchmarks that we're looking at meeting, so that in the first year, so that we can continue funding for years 2 and 3.
Where did you get this from? Were they benchmarked at all, or just?
I looked at the metric, like some global metrics from PORT toolkits, and then I also took into consideration what the community needs are and the availability and capacity for EMS, and that is a big. We have a high call volume, and so if we can also build capacity for the rest of EMS, it's a value add for adding in the PORT team, and so that was one of the indicators that I wanted to include there. But the rest of it is kind of global measures for PORT. Does anybody else have any questions about the port strategy?
72 hours of normal response? Within, you said within 72 hours of response back to the normal response?
I think, yes, ideally, they would be responding sooner, but his, yeah. Sometimes individuals are hard to reconnect with, so it takes them a little bit longer. That's not to say that they're attempting sooner than 72 hours.
Okay.
And so for naloxone distribution, we gathered information from different departments in the sheriff's office and looked at what the needs are for naloxone and built a budget around distributing at least 650 kits per year through EMS, community-based outreach, the vending machine, leave behind kits, our partner network, justice system, and the school system. And then our third strategy with our county-led initiatives is the peer community navigator. And so this person it's a field-based position that would work alongside the port team for longer-term case management. They would also be able to work with justice-involved populations, the emergency department, and they would serve as a bridge from emergency services like EMS and the ED into treatment. So it's an extension of that port service that might only last 3 to 7 days. We would have longer-term case management in a neutral position that would be able to make referrals to any agency. And so the indicators for this position, we're looking at percent of referred individuals who engage with peer services. We want that to be greater than 70%, percent of active clients who remain engaged. So these individuals that would be referring to case management, they would have already come through a point of entry like the emergency department or port. So that's why this percent is a little bit higher. So we've already made connection with them and made contact, and they're willing to go into the program. So we're looking at 70% of individuals engaging, greater than 60% of active clients who remain engaged, number of clients connected to at least one recovery, medical, housing, or social service. We want 100% of the people that we're working with to be connected to at least one service. And number of cross-sector case reviews held with port, EMS, and community providers. So we want to have regular staffing interactions with our community partners so that we're not only serving individuals, we're building our system of care and building our provider network. And so our total budget request with our county-led initiatives, port, naloxone distribution, and the peer community navigator come to around $880,000 for the first year, and that will drop somewhat as some of these are like startup costs. But this is going to be really the foundation that we build around. So our emergency services, our port team, our community network building, we're going to be able to build out from that with some of the other services that we're seeing come in through the proposals. So I'm going to pause there and see if you guys have any questions or feedback.
Any questions?
Who is the navigator employed through?
The county, it would be through our opioid response department.
So would they be housed with EMS or?
So the port team, the port peer co-responders will be housed with EMS. Our peer navigator would not be necessarily housed with EMS as much as like complementary to or working in tandem with the port team.
You know where they would be located or housed?
How do we get their services? Like if we were gonna, like if somebody's coming from the hospital, everybody's in there getting released, is the navigator following them in their service? Is that their goal there?
Mm-hmm. Right, so
the person's, they're right call when they come to the hospital, and that's how it works.
right. Mm-hmm. So we're looking at initially like those referrals from hospital, jail if it's needed, port team, but we want to build up a system of care to where it's a known resource where that person can get community referrals, community-based referrals from other agencies or from individuals looking for resources.
So if this is Eric. Okay, if I had someone that was, that I know was at the ED from overdose, and I know that they're getting ready to get released, I would just simply call EMS or who would I contact to get the navigator connected with my person?
So in theory, you would call like our opioid response team.
Okay. Okay, so that would be, and then the linkage from there, if they're coming from the hospital, usually most people get dropped off at BUCM. So they would be with them, bringing them there, so that gap is gone. Because usually what I have is just a drop off. No other services, nobody there. They're just, this is where I was told to come. That's how it works.
I don't
So
know.
that shouldn't happen anymore.
Yeah, we don't have all of the details worked out as far as like processes for transportation. That's something that we would work through, but regardless of if they're transporting from the hospital or not, that person would essentially be there to assist with paperwork, help get them, signed up for whatever they need to,
Okay.
And help get them to where they're going, whether they're the ones that are actually transporting or not.
Do you think that this one person will be enough to handle all of this? Because that's going to be a lot. And just thinking about one person trying to help people get those services, I just wonder, will they just, like we talked about earlier, would they be in a pond with one nostril above the water with their toes on the bottom?
Yeah. So this person, I think, is going to be really central to creating like some coordinated entry, but it's going to also help be the hub where we have the spokes of other providers. So our idea here is to create the central hub where we can build out around it. And the RFP process is a good example of how we're looking for what our providers can do to expand capacity. If they need additional assistance to be able to create a continuum of what we're doing with Port and the peer navigation. So we won't be doing it alone. Our goal is to also support the whole network of providers. And then if we see a gap where our peer navigator is saying, really, I cannot get anybody in housing. I've tried, like I can get treatment, I can get food, but I can't get housing, then that's where we come back to the table as part of our strategic plan and say, we really need to focus on recovery housing as a priority. So the teams that we're building, especially with peer support, and engaging people that are actually seeing what's happening in the community, it'll give us really a good ability to observe what's happening in the community and then be intentional about the strategies that we're funding.
It may be a point of clarity, and I don't mean to interrupt, but the Port team has 4 medics, but it also has 4 peer support specialists. So if you think about, Karen's question about handing someone off or who do I call, there's really 5 people that are managing that. You got 4 peer support specialists on the Port team that are co-responding, but there's 1 or 2 overdoses per day. So they're going to carry short-term caseloads and be part of that transactional component. And then the peer support or the peer community navigator is a neutral source that tries to put people into the system as a triage. So there's more than just one person, I think, handling some of that traction.
That makes sense.
And I think this goes back to your point, Sheriff, when a few months ago I was looking at what are the priorities as far as treatment options, and I just kept thinking we need it all, and I think this really is a solid starting place for building out. But I do think the need is there, and we'll really have to be collaborative in our approach.
My question is, for you guys, anyways, will the peer navigator, will they be dispatched with EMS to certain calls? Because I know certain patients we have, they do not come with us because I work in EMS, and I know that they want to be where they are. They don't want to go to the hospital. So will this person go to those calls aside with the peer support and the community paramedics? Where is that bridge going to be for those who will not come and get care? That's my question.
So the port team will have a community paramedic and a co-responder. And the the community peer position will be like community-based. But we'll have a peer support specialist co-responding with a community paramedic. So we'll have 2 people responding to all of those overdose calls. And then they'll be able to follow up as needed or to stay with the person if they're, not wanting to go to the emergency department, but needing that peer support service.
Okay. So it's still all bridged together under the same umbrella, okay.
Yeah, the port team is more like an immediate, this person's had an overdose, how can we get them in a space to where we can connect them to longer term treatment? And the peer navigator position sort of serves as that intermediary where the port team can go on and keep responding to emergent calls. Your peer navigator position can work with that person on a longer term basis to make sure that they're getting into treatment and staying in treatment. And one of our indicators that we talked about last month was that we're seeing a reduction in overdose fatalities, but we're not seeing a reduction in overdoses or treatment uptake. So we want to have some strategies that will help engage people in treatment and get into that long-term recovery space.
Okay. So correct me if I'm wrong. An overdose takes place, the port team goes out with peer supports. They then hopefully will agree to go to the hospital if they need to. They go to the hospital, there's a warm handoff from the port team to hopefully the peer navigator, and then a plan is made, and then they're discharged, and the peer navigator can follow up with them. And so there's a streamlined process.
And there's some overlapping abilities. So your peer co-responders can also do case management work also. So depending on what the volume and the need is, they can work collaboratively with each other to make sure that the person's needs are met.
Sounds great.
All right, you guys ready to move on to the next section?
Think so.
All right, so now we're going to talk about the RFPs. We had an open RFP asking for community agencies to submit proposals for programs that are either new or expand existing capacity. And these programs had to fit within one of the 12 strategies of option A of the NCMOA. And that's the way that we're able to fund it through opioid settlement. So that was the first criteria. The RFP was open from June 11th through July. I'm sorry, I think it was written down on another piece of paper, but it was open for approximately a month and closed on Friday. After it closed Friday, we had an internal pre-screening. So we had proposal submission, and then we had a pre-screening review, which included our finance department, the health department, DSS director, the sheriff, and we looked at does the submission fit within one of the 12 strategies of option A? Is it feasible? Can it be implemented? And we looked at what we could recommend to move forward immediately, things that maybe need to be revisited and revised for resubmission, and things that weren't ready to go during this phase. And so after the pre-screening, we've developed recommendations for you all for the items that are ready to be moved on to the next phase of this process, for you to look at, review, and then decide if you want to move on with those strategies. That will then go to the Board of Commissioners for final approval before the program is launched. And so what we're looking at today is the actual strategies. Like, what are the programs proposing that they want to do? Like, what's the impact and the steps that they're going to take to either grow capacity or expand their existing services. And I say that because part of this process is if you all decide that you want to move forward with any of these proposals, the next step internally with the county is for us to go and meet with these agencies and refine their budgets and look at their scope of work to make it really solid solidly fit into the option A of the NCMOA. So any questions there? So here is just I think I've given this to you all before. This is option A strategies. These are the strategies that can be immediately funded. Option B strategies are the things that will need to go through the collaborative strategic planning process to unlock. But these are the things that are high impact and can be immediately funded through opioid settlement without following the collaborative strategic planning process. And so we received 11 submissions through this process, and you can see that it was a range of programs and a range of funding requests. So we have a Caring Alternative, BUCM, Burke Recovery, Catawba Valley Healthcare, Center for Collaboration, Motivation, and Innovation, Christ-Centered Recovery Program, Good Sam Clinic, Granite Falls Comprehensive Treatment Center, High Country Community Health, Spark, and the Cognitive Connection. And so you can see that several of these were treatment-based. We have one recovery housing, some MAT programs, and expansion of services. And so as we were pre-screening these last Friday, we looked at what things are ready to move forward, what things need to be revisited, and what things don't fit into the MOA or our duplication of services. And so the not recommended to proceed at this time, we were looking at BUCM, the Center for Collaboration, Motivation, and Innovation, Granite Falls Comprehensive Treatment Center, and the Cognitive Connection. And again, this was based on either did not fit criteria, was a duplication of service, or it needs to apply at a later date. So the category for revisiting application for resubmission, these proposals were meeting gaps in the community, but need some revision in their application. Catawba Valley Healthcare, we're looking at diversion and reentry, and this is some conversation that we're having with the justice system to see what exactly the needs are. So we feel that revising that application to better fit in with the needs in the justice system at this moment would help them be able to move forward. Christ-Centered Recovery Program Ministries was a long-term faith-based recovery housing. This was the only recovery housing program that applied, and they need to look at more of a service delivery approach instead of a capital expense approach. So again, we'll go back and give them feedback to help them revise their submission. And Burke Recovery was proposing a substance use intensive outpatient program, which is a need, but it was a duplication in another proposal that was a little bit more comprehensive with services. And so I recommended to proceed. We have a Caring Alternative that is recommending or proposing substance abuse comprehensive outpatient, substance abuse intensive outpatient treatment. So that's SACOT and SAOP. And those are treatment programs that work really closely with recovery courts. So a person comes to the program either 3 or 5 days per week, depending on which program they're in, and they receive intensive outpatient substance use therapy. And a lot of times this is a component or requirement of their terms for recovery court. And so right now, we don't have an active SACOT or SAOP program that's located in the county. Our residents are having to go outside of the county to receive the service. So it is a big need for the citizens here in the county. And that fits in with option A strategy 2, evidence-based addiction treatment. The Good Samaritan Clinic is proposing a bilingual licensed clinical social worker that would perform what we call SBIRTs. It's a substance use screening. So the clients that are coming into the Good Sam Clinic would be screened through a social worker and then connected to services. High Country Community Health is proposing an expansion of their low barrier medication assisted treatment MOUD program. And that fits in with option A, strategy 2, evidence-based addiction treatment. And Spark is proposing family-centered treatment to help prevent children from going into foster care, or to help reunite families through treatment support. And that would fall into strategy 3, recovery support services.
Katie, what is Spark? Is it exist in the county already?
It does, yes.
What, I know that's an acronym for something. Do you happen to know what it is?
No, I don't think it is an acronym for anything. I think that's the name of it, yeah.
It's just Spark.
The C, not a K.
Spark is similar to ACA, and they do a lot of good work in the community. Spark,
Yeah, I know what you said.
they're similar to ACA. They provide a lot of really good enhanced mental health services in the community. They do a really good job.
You're going to have to tell me what ACA is.
A caring alternative.
Okay. Lots of acronyms.
All right, so what we need to talk about and agree on is if you would like to recommend any of these 4 that through the pre-screening process we feel are ready to move forward. And again, if you recommend that any of these move forward, we will be meeting with the programs to help revise their budgets and the scope of work. So we're just looking at the actual program and the strategy. So if you want to recommend that any of these strategies or all of them be moved forward, we would go into the next step, which is the scope of work budget before it gets to the Board of Commissioners.
All right, thank you, Katie. As part of this motion, ladies and gentlemen, you'll see on your agenda the 3 items that Katie's already talked about, the port team, the community navigator, and then the lock zone distribution. And then these 4 recommended items to proceed. Maybe to help us move along here, let me first ask, are there any of these 4, any that you have concern about? Staff has already reviewed them and feel they're acceptable to proceed. What's the, any concern with this group on any of these 4?
I have questions regarding sustainability. So are we going to have a request in a year from now? I just have, I have questions regarding sustainability.
To any particular one, or?
Good Samaritan Clinic. I think that one was one of the lowest ones, is that correct? And so is that going to be an annual cost or a one-time cost?
So the process that's set up now is we have this RFP that will cover an annual budget, and then at that point, the program would have to reapply. So part of the conversation that we can have if we move forward with any of these strategies is to submit a sustainability plan.
Yeah, I would point out, when we were going through the proposals, though, like a caring alternative with their intensive outpatient, they gave a 12-month, 4-quarter proposal, and by Q4, it was based on what they could bill, it was almost break even. So, I mean, I think that there's some of these that will have a sustainability component and be able to stand on their own. They're basically applying for a grant for startup cost. Some of them not, and it's more about, does the community benefit from a short-term infusion? Good Samaritan is something that the county also supports outside of opioid settlement dollars, and they apply every year, and sometimes it's for different stuff. This year they needed some additional physician supplement funding. So, you know, I think that that's going to be, as Katie said, a case-by-case basis. But some of them, I was impressed that, especially for caring alternative, I think in the 4th quarter, they were within, you know, like 10, 15% of paying for the program based on what they were able to bill.
And Katie, as part of this process, a reevaluation as to their effectiveness has as we go along as well.
So what we'd like to do with the contract, if we move forward with any of these strategies, is to build into the contract reporting requirements and also presentations to you all regularly. So monthly reporting requirements, something along the lines of like a quarterly or presentation at least once or twice annually to you all, and then grantee meetings with the opioid settlement team.
I want to follow up on Katie's concerns too about sustainability. And Jeff just now touched on it. When you went through these organizations and talked to them, are they going to build in new programs? Are they going to take current programs that seem to be working? How many more people are going to be involved in the county in the program? You're going to have to convince me that the money that we're going to give them is actually going to do something. I want some guarantees. We worked hard to get this money. I want some guarantees that the money's going to be used. How did y'all feel when you talked to these people? Do they understand the option A's, the option B's? Do they understand the MOUs? They've been here doing work, okay? And here's a golden opportunity. Somebody comes in and getting millions of dollars, and they're going to go out there and start reaching for that money. I want a guarantee of what's going to happen. Convince me that happened when you talk to these people.
So one of the reasons that we did the pre-screening is that we wanted to verify that these things that we're moving forward, or we want to look at moving forward, do fit within option A. And so we had an application that didn't fit within option A. So that one went into the, we can't proceed with this at this time. So we're using that pre-screening to make sure that they do fit in, whether they understand it or not. And then the system that we set up for reporting will also be for, we want metrics that meet the requirements in option A. So we want to know how many
Who's going to take a look at that? Is that you by yourself? You and Brandy or somebody else?
So I'll be gathering it and doing some analysis, and then we will look at it as a committee and a group. And then that way, when you guys go to make a decision, if someone reapplies for funding, or even if they're not meeting the.
That's my next question. What if they don't meet it in the process that after we get them in 30 days, they're not doing it?
And so we had.
What do you do?
The model that I would compare to, Johnny, and you were right in the middle with all this, but the county back in 2019 got a Department of Justice grant to pay for recovery court that funded it. It was supposed to be a 4-year grant. It was extended a year because of COVID. The grant was not renewed primarily because of lack of performance. Right now, all of the recovery court functions, which is currently, I think Katie said, at 16 or 18, but it can be expanded to 30. And it has a 60% non-recidivism upon graduation, which is outstanding. I haven't seen numbers that strong anywhere. But when we began to refund it in October, we told the board, we'll report back to you in April about performance. So you were obviously a part of that renegotiated performance contract in October. And we put in, simple measures. How many people are coming to class every day? Positive drug screens. How many people are maintaining employment? Those type of very measurable, very straightforward performance metrics. And in April, we were able to demonstrate to the Board of Commissioners, this is working. So we're paying about $12,000 a month to the Cognitive Connection to run recovery court, which has a component of intensive outpatient counseling, which is 4 or 5 days a week of several hours. And that using that data, we extended it through December of 2026 because it's working. It's also funded through opioid settlement dollars, but I think we have a template for a performance contract, and each program is going to be a little bit different. So for intensive outpatient, it may be where are your referrals coming from? It could be peer navigator, it could be the hospital, it could be maybe some recovery court people there, and we're able to expand it locally because transportation is a real barrier. Cognitive Connection said the class could handle 30. We've only got 18. It's got outstanding outcome results, but the challenge is to go 4 or 5 days a week when you don't have a car and you're riding Greenway, you're gone from your house 8, 9 hours, and it's impossible to hold down a job. So those are real barriers. So I think these are some new things that our community doesn't have, and I think each of them will have. For the things that the county is doing in-house, naloxone distribution. So we know the number of overdoses has not changed at all. but we have a 50% reduction in overdose deaths right now. In 2025 and the back part of 2024 compared to the last 3 years, deaths are down 50%. That's good news when
Is that
overdoses are
because of
flat.
naloxone?
I think that's a big part of it.
Okay.
Every first responder, every sheriff's deputy has been flooded with naloxone, and I think what I hear is keep people alive until they're ready for recovery. If we can do that and give them an ecosystem to work through things like recovery court, things like outpatient counseling, I think that's the goal that we're trying to do. Port, I mean, I think that's going to be an easy thing to demonstrate, and we put the engagement rate and the 5 metrics as well as the peer navigator. Internally, I think it'll be very easy to measure performance and report to you all and to the community on how it's going. For these, I think it's going to be a case-by-case performance contract, and what we're asking this board to consider is, based on concept, these are services that aren't in Burke County right now. It's expansion or new on every single one. And if we understand where we're trying to go, Katie and her team will go back and draft a performance contract along with a re-engineered or a redeveloped budget, because these folks, lots of the budget submissions had things that weren't fundable or things that were duplicative. So they said, here's what we can do and here's how much it would cost. So our job between now and August, if you say, yeah, we like the idea of intensive in-home foster care treatment with Spark, we'll sit down with them and make sure that there is a value engineered budget with clear performance metrics, and then put that in front of the Board of Commissioners in August. And then periodically or monthly collect data, periodically update this board. And if any time they're not meeting the performance requirements, just like with the recovery court, there's an immediate contract termination at that point.
So this motion is basically to approve the further investigation of what those services would be, and
if this board saw value in the proposed programs, expansion programs from Caring Alternative, Good Samaritan, High Country, and Spark, Katie and her team would meet with each of those organizations between now and the August Board of Commissioners meeting, try to come up with a value engineered budget, and present that in the form of a resolution to the Board of Commissioners. So this board is, I guess, endorsing the concept. She'll then finalize a budget, get the program moving along with performance contracts, and then when you are all back together in September, say, here is what has happened based on your recommendations of concept. Does that make sense?
yeah, I think so.
So when you say pull the contract, are we giving this in a lump sum, or is this
No,
a quarterly payment?
It's
where-
drawn down in most cases based on, but there's some of these folks that what they put in their proposal is not how it'll be the budget side. So again, I think we're getting wrapped around the axle on the budget component when that hasn't been scrubbed in any way yet. So for example, our only submission that's not one of the 4 recommended for recovery housing ask us to liquidate their mortgage. That's not an allowable cost, right? But they are the only provider that has recovery housing in a 12-month program. So that indicates there's value in re-entering that program. Some of these folks too will have to look. For example, High Country proposed as part of their submission the creation of a peer navigator. Well, we're going to do that. So clearly, we're not going to fund it for a vendor, because we saw value in neutral peer navigation, so you don't have vendor bias, right? So that'll come out. That's what I'm talking. The idea is, do we want to expand MAT services in Burke County? High Country has said we can do that. So our job would be, where can you do it? How often? How many people will you serve? Negotiate a performance contract, present that for funding in August, and then report that back to you all in September. Just like Katie said, though, if you don't, with Good Samaritan, if there are concerns that there's not tremendous value in a bilingual clinical licensed social worker that's serving that low income and largely Hispanic population, then that's not something we need to follow up on. We would just work on the other 3 or the other 2, and then report back. And part of this is about pace too, right? We also, I think what we heard from you all last month was we want to have some pace. We want to hit the ground running. So there was direction given to develop an naloxone, a port, and a peer navigation strategy. We were able to do that internally. It was only a month ago we met and we had the RFP or RFA, if you really is what it was, proposal process out for almost 4 weeks. And so our turnaround was fairly swift so that we could get options out and try to make some investments. But I think Katie's done a good job of coming up with options for you all to consider.
When are the next RFPs being requested?
We have 11 out, 4 that were recommended for advancement, 3 that need follow-up. We would circle back on these 4 from a budget perspective, the 3 that were needed for follow-up. So with Christ-centered recovery, for example, between now and September, we would try to go meet with those folks and develop their proposal. But there really isn't a reason, in my opinion, and I know Katie feels similarly, that the RFA process can really be posted all the time. And as submissions come in, they can be evaluated. It's very different than a typical RFP. So when we buy patrol cars for the sheriff, we say we want a Ford Explorer that does, and tell us what you can do that for. This is very different because we're saying, what can you do and how much does it cost? So it's not a traditional bidding process. It's more of a narrative submission that can be evaluated. And that can really honestly be fluid based on the gaps that the peer navigation team and our opioid settlement team and this board sees in the community.
So new ones can come in at any time?
Anytime.
Okay. So, I mean, I hear what you're saying, Johnny, and I mean, I also have some concerns, and I mean, I've voiced those with some people in the community, and we've talked about it. I think all 4 of these are really great providers, and they're all very experienced, and they're good at what they do, and these services are very well needed. I think the question that I have, and maybe some others have, is what is the end point when it comes to private providers? Is this going to be a constant, now I want this service, so I want this much money. I want to add this service, so I want this much money. Like, what is the end game? Are we going to constantly be giving to private providers to expand their for-profit companies? Or are we going to talk about some other outside of the box ideas? Are we going to talk about some nonprofits? Are we going to talk about some other things? Or are we going to be like, hey, your idea sounds great and you want to add this service, here you go. And I think that's the question, but that also goes into option B strategies, not option A strategies. So I understand exactly what you're saying, Katie, that these are good right now for things that are not, that we don't have. We have to have that for recovery court. We need a bilingual LCSW. We need to expand MAT, and we need recovery services through Spark. So that makes perfect sense. I just would like to know at what point is the end game for providers. So it's not just a constant, if they're open all the time, it's not, oh, you need this here, here, here. And is the community going to feel the effects of whatever the total that ends up coming? Are we going to feel $1.5 million of a difference? Or are those companies going to just have expanded services and the people out there are not going to feel these differences? That's my question. And like Johnny said, that it goes to where it needs. We're not gonna cushion this money. I mean, I hate to be blunt, but in my opinion, this is blood money. This is on the backs of people who have died, and I don't want to see it used to buy couches and chairs.
Which is why, and we agree with that 100%, which is why not one of these has okay, this is what I submitted from a budget perspective, and that's going on to a resolution. That'll be a very rigidly reviewed process between now and any submission. And if they can't reconcile between the provider and us, then they won't go. But to concept earlier, you walked through a systematic, okay, I overdose, this is what happens. If you piece some of these RFPs that were, or RFAs that were recommended for advancement to someone has an overdose, it comes through the 911 center. We average 1 to 2 a day. We have co-response medic to make sure, stabilize, reverse overdose. Peer support co-responds, engages. We hope to have at least 60% of folks who do tell us that they would like to be embedded in service. We then link them out to MAT or get them connected with some type of recovery through maybe it's intensive outpatient, maybe whatever it is, but there's at least a process to get them on their way. And so when you ask, does $1.5 million create an impact in the community? If it goes through the 911 system, it is a funnel and a feeder system into some type of recovery support. And I would make an argument in a week's time, that's 10 people. and that compounds week after week and month after month, I think that it will make a difference. I think people will feel it and see it.
Yeah, I agree. I mean, I know they're needed, and it may seem like some providers adding some services, but I mean, people really use these services. From what I can tell, a lot of these services at Caring Alternative, I don't know about Spark, I know High Country, they sit on wait lists. Their caseloads stay full. And so that says something right there.
So I think to that point, we're gonna need data of the people that we refer, and when they're seen, not necessarily their data, it's gonna need to be the data of people that we've referred to make sure that the money is having the impact.
Is the goal for Caring Alternative to pick up the reports with the SAIP and stuff to stop the traveling, or is that just, they don't have a choice?
They have a choice.
I went dead. What did you just ask?
I was just curious if now at the Caring Report, there'll be a choice because you have the Carbon Connection that does the SAIP right now, and then if Caring Alternative picks it up, is that giving them a choice to go to Hickory or just go?
Mr. Chairman, can I make one other point that we talked about that I don't think has been fully articulated? In Burke County right now today, we have about 186 children in foster care, which we've all talked about is unproportionately high when you compare it to our community population. And there's lots of social determinants and data figures that I could give you an hour talk just about that. But when you hear our foster care social workers talk and our DSS director talk about the lack of options, so a parent goes to court, if there's a removal of custodial rights or removal, child's taken into care, there's certain steps that a parent has to go to for reunification. And just like recovery court, many of those services are not in Burke County. This starts to bridge that gap too. You're going to have a higher percentage of families that, and there's clear data, again, I don't want to get into the weeds of foster care, but there's clear data that if a parent begins that journey of reconciliation early in the process, that happens. And if they don't, that likelihood of that child getting out of foster care for permanency placement goes down. And there's further clear data about jail admissions and substance use disorder and all those things for children who spend longer periods of time in foster care. And so I say that as an auxiliary benefit of adding some of these services that you're considering. It helps in a residual compounded way, not just with specific 911 overdose calls.
I think what I'm hearing from this group is that we want to see measured data. We want to see that these programs are effective, and if not, we move on to something else. That I think what I'm hearing largely from this group is we want to see data. We think they're good, but we want to be sure that we work out the MOUs so that everybody understands. We want to see what you really did.
So is that a possible process that rather than it automatically advancing to commissioners for approval, that it would come back here for review here before?
It is. It's just if we stick to our standard schedule, it's going to cost you 2 more months before you do anything. And what we can do is draft them and circulate them to the team. I mean, this is not an elected body. So there's the open meeting law, you can't make legislation, in other words. So if the team wants to meet with these providers and come up with performance contracts that would kind of roll up into this spending resolution and circulate it to the team, we can at the direction of the board, from a staff perspective, we can certainly do that. Or we can bring it back to you at your next meeting, but that's not until September, and then that would be an October county commissioner meeting. So it would just slow implementation down about 60 days. Or you could have a special meeting.
The RFQ, they met some metrics of 12 things up here. They met those metrics when they filled out the application, but we need to know some more. Is that making sense to anybody? I just want you to get the face to face with them and let them explain exactly what they're gonna try to do. Karen, you do that all the time, don't you? Yeah.
So I think the idea here, though, is to get some things going, and I understand that, but I also understand that a rushed plan is never a good plan.
Exactly.
And the money is sitting there only building interest. So, I mean, I hate to upset anybody, especially in the community or otherwise, to slow things down, but yeah, if we could ask some more questions, and make some suggestions towards the contract. Like I said, I read through every single one of them. One provider offered to match it and pay half of the cost. Other providers wanted the full cost. I think that there's things we can talk about that can go into the contract. I mean, once profit starts coming in, can we get 1 or 2% back? I think there's a lot of questions of like, we're just giving this out, or is there a way to generate some money back towards some other underinsured, someone that's not insured? I think there's a lot of questions, and again, like if you fail to plan, you plan to fail. And it's just, I mean, if everybody doesn't care to slow things down and us not vote on these at the next commissioner meeting.
On the 15th and 14th, correct?
Right. So can we go ahead and vote to move forward with the first budget recommendations and then slow down on the RFP submissions? And ask to meet again and meet with each provider and talk about what should go in the contract? Or make suggestions at least?
Is that something, Katie, that perhaps those who have interest in doing that could meet with you and your team during the process once you kind of get things together? And I don't know if it would be possible or feasible to do that and still stay on an August schedule. I don't know if that gives you enough time and the group time to review those, or would you still rather come back as a total group? Of course, we can still get a lot going on with these first 3 items, and then.
So are you recommending we meet with the 4 providers, with members of this committee, and then bring that report back to the committee at the September meeting for a decision at that time?
I mean, what additional questions do you have, Dr. Frank?
Well, my first question, Mr. Chairman, was going to be, is there, I don't remember how we enacted the schedule. Is it possible for us to have a meeting in August to move this along quicker rather than waiting for the 2-month piece?
Our minutes say every other, right?
That's what our minutes say, but I don't.
You can schedule a special meeting. It's just a special meeting, not a regular meeting. Regular meeting is every other month, and we staggered it between county commissioner and advisory board just so that they would be complementary to each other. But if you want to meet in August, you just need a motion and a second and a vote to meet in August.
So
It's a special meeting. Yeah.
So that would be one approach to move it along quicker if you thought you could get that information.
I guess, is 30 days really do a lot for us at this point if we can get the first 3 started, and then that would give you more time to.
I mean, my off the cuff is that, and I'm basing it on just, the recovery court process, is that there are standard performance metrics and there are very, achievable budget conversations with each of these. So I mean, I'm probably tend to lean on the overly optimistic side, but, I feel like we sit down with these folks and spend a couple of hours with each of them with a standard template on a performance contract. We could probably come up with at least a starting place. I mean, I hear you on think outside the box and be innovative. I think we should try to do that in everything that we do. But, if we take a full 8-10 hour day and bring them in for 2.5 hours at a time and just crank through it, we could be ready pretty quick. I think if that's what the board wants to do, staff can certainly accommodate that and at least see where we're at. We can take as much time as this board wants. I want to be clear that I think our team is prepared to do whatever it takes to stay on schedule.
what's the pleasure of the group? You want to try to get this done, meet again in August, and look at what the group.
I guess my concern would be that if we're going to approve the port piece and then we don't have anywhere to send them because these services don't exist locally, that, we're going to have one piece without the other. So if we're going to slow it down, I think I would be inclined to try to meet in August and see what we can get to have a little more information, since it seemed like there was a fair amount of concern about that piece.
So even if we hold off, because there's SAOB in the county, it just comes out of the county. So even the port team got started, they did a place to try to send somebody. Because we have people inside BUCM that do SAOB and IOB. So there's still a place to send them, it's just not, even for the port to get started, there'd be a place to send them.
Well, these services are gonna take a long time to get off the ground.
Yeah, so there's still a place, yeah.
So I guess my question would be, what would we meet about in August? I do trust Katie and Brandy. I think they're gonna do a great job meeting with these providers. What additional information does everybody want in August?
The biggest thing people were asking for was just some data to see where you at now, where you go.
I think what I'm hearing is what the group would like to see is, we're certainly not going to see any real data, but they'd like to see what data are you going to compile and how are we going to measure that data. I think that's what I'm hearing. And perhaps that could be ready by sometime in August. And if that were true and this board could agree to that, then could continue on to September commission meeting.
Maybe can we do that? Can we request some supplemental documents of how they plan on measuring their data, a sustainability plan? Does anybody want anything else?
We may be able to do that just via communication, via email, once Katie's got that together and get that out to the group. And if you have concerns as to what they're putting together, then voice that back and forth so we can keep it kind of moving. Does that work, or do you want to have a formal meeting?
If we're able to find some time in August and staff are able to work through measured outcome data and put some key performance indicators in place, which is I think what we're talking about. If you're willing to meet again in August, we could also have someone from each of these organizations come and speak to you and answer your questions. Obviously, we need to do a lot of front-end work and present something to you and get something in the packet and all those type of things, but there's also nothing wrong with inviting them to come and answer questions from the board real time.
I'll go to plenty of meetings, but I think it's important that we all get together and hear the same information. I know the emails are convenient, but, just today, I think just today I've heard some things from some people that I hadn't thought about. And so I think it is good that we meet, and I know, like everybody else, I'm meeting to death, but I think it's beneficial that we all get together and hear that same information and then make that vote.
So I'd like to make a motion to approve a meeting in August to discuss the information that's requested. And I think it'd be worthwhile to hear from the 4 providers in person about what they're proposing and how that would play into our plan.
Okay. Let's look at your calendars. What about August 12th?
Same time?
I won't be here that afternoon.
Everybody else look okay? Looks like the majority of the group's good, so let's go with August 12th. Okay, so with that, all those in favor of meeting on August 12th to hear from the 4 recommended RFP submissions and hopefully with some more details about how they would collect data? Okay, all in favor, that's good. All right, so in terms of the other 3 items, are we good to go ahead? Any concerns on any of those 3 items about moving them forward? Everybody in favor of sending the port team, the community navigator, and the naloxone distribution forward to begin that work?
Motion to approve.
Second. All in favor? See, that's all of us. Johnny, you?
Yes.
Okay, so that's all of us. All right, very good. Thank you very much. That brings us on to reports and comments. Receive any other comments from anybody? Anybody else got anything that burning on your mind you want to say before Mr. Manager?
Checking calendars, and we can push them back a little bit. But the Board of Adjustment meets in this room on the 12th at 4:30. So if we're at 3:30, that gives us 1 hour. I can work to push them back a bit, or we can start earlier than 3:30, or you may think that an hour is good enough. But I just want to get some direction on what your thoughts are there.
Is it possible to meet earlier?
Can you meet in a different location?
Board of Adjustment,
Well, I was talking about this board.
well, we don't have we stream on YouTube here, and we have the audio. That's the only, we don't have the infrastructure in other spaces. But I mean, again, bumping Board of Adjustment back to 5 or 5:15 is possible, or this group starting at 3 is possible, either or, but I need to work on that.
We may need to do both if we're looking at, hearing presentations from four agencies. We
Sure.
may need to bump it up a little and bump them down a little bit.
Yeah.
2 or 2:30?
No.
And if possible, could we get the data emailed to us again? Like I was able to look over the information last night, coming in here and understanding kind of what we're going to look at. But if we get it emailed to us beforehand, we can look it over and then come in here prepared to know what we're going to discuss and what's going to be said.
Same day, a little earlier, that 2:30 work? Okay, any other things to discuss? Next time, let's arrange this where we're facing, turn the U where we're all facing this board, okay? All right, I hear a motion to adjourn. All in favor? Hands up. Everybody, thank you very much. Appreciate your time today. We'll look forward to seeing you next month.